Awesome. All right. Good morning, guys. I'm Spencer. I'm doing a topic on tuberculosis today. Special shout out to our EKG Rads and Farm team, Drs. Kathwala, Tang, and Dr. Walsh. At the bottom of the screen, you're going to see a Vivox app screen session ID. If you go to the Vivox app, you don't have to sign in for anything. You just enter the session ID, and we can use it for some interactive stuff. It's always going to be at the bottom of the screen, so take your time with logging in. Some quick facts about tuberculosis. It's present worldwide. Worldwide, in 2020, there are about 10 million cases reported. It's still the 13th leading cause of death and the second leading infectious killer behind COVID-19. In the US, we have a rate of about 2.2 per 100,000 in 2020. And in New York City alone, there are 445 cases reported in 2020. And our population around Kings County Hospital has a citywide rate, which is above, has a local rate, which is above the citywide rate. So in our population, it's about like 5.5 to 12.1 per 100,000. Tuberculosis, as we all know, is aerobic bacteria. It's slow growing. It prefers high oxygen content. Transmission usually occurs from aerosolization of bacteria and inhalation of droplets. And the surprising thing is that only like 30% of patients become actually infected after droplet exposure. Once the organism reaches the lungs, you have your activation of your host response. There's a rapid immune response, usually in the regional lymph nodes around the area. Some of the bacteria is usually contained, and some of the bacteria might contain granulomas. Some bacteria might just survive in the lymph nodes. Granulomas form. This is a sign of primary infection. Infection could also spread hematogenously, lymphatically. Usually it prefers areas with high oxygen content, such as the apical and posterior segments of your upper lobes and the superior segments of your lower lobes, the renal cortex, meninges, and the epiphyses of long bones, and the vertebra. And here, the bacteria can actually remain latent for a number of years. Latent infections are subclinical. They're asymptomatic. They're usually non-contagious. However, 1 to 13% of patients, healthy patients, usually have some sort of post-primary or reactivation disease. The risk for reactivation is usually higher in those who are infected with HIV and those over the age of 50. And just around 5% of patients with latent disease may actually progress to active disease within 2 years of their initial exposure. We're going to go into our first section. We're going to talk about EKG findings first. And for this part, you can look to your Vivox app and you'll see a question pop up just about now. Oh, sorry about that. All right, just about now. So I'll give you guys a couple seconds just to answer the question. Maybe 15 seconds or so. See, there's 20 of you logged in, 20 something. All righty. So here in this question, we have a 53-year-old man with a 3-month history of anasarca dyspnea on exertion, paroxysmal nocturnal dyspnea. The presentation is on tuberculosis. The cause is going to be tuberculosis. So I found that tuberculosis, there are some figures online which say that tuberculosis is associated with up to 4% of cases of acute pericarditis. I don't know how much I believe that. I've seen this figure as far back as like papers from the 1950s, 60s. 7% of cardiac tamponade, and it's the leading cause of constrictive pericarditis in endemic regions worldwide. There is not much evidence on actual EKG findings specific to tuberculosis. There was only one paper which looked at 100 patients and abnormalities they found in the EKG and echo. And we'll just talk about those findings in here. So for the first EKG here, I'm going to run another poll. Awesome job on the question. Just feel free to shout out on the app what you guys see. So for this first EKG. Excellent. Yep, sinus tachycardia. T-wave inversion in lead 3. I actually didn't notice that when I first saw this. I was actually going just for sinus tachycardia, but you can actually see non-specific STT changes in tuberculosis as well. Sinus tachycardia in this specific 100 patient study was the most prominent study, was the most prevalent finding that they found on EKGs. This next EKG here. What do you guys see? Anything specific? All right, great. So I see diffuse ST elevations, ST, oh, there's a lot of stuff popping up. Diffuse ST elevations, exactly. So in this one, I was trying to point out that there are these diffuse ST elevations and also PR depressions. However, more specifically, there was this specific finding. So it's a downsloping TP segment in lead 2 specifically. Apparently, it's called the Spodek sign. It's something that's specific to pericarditis. And it's just something that can be used to differentiate pericarditis from something else like a STEMI. Yep. This one right here. Great. Yep, electrical alternates. So in this specific study with 100 patients, the methodology was a little bit shoddy, but they did describe seeing pleural effusions, pericardial effusions on their echoes, which was the most predominant finding they found. Low voltage, electrical alternate, sinus tachy on this one. And this last EKG here kind of pointed out the abnormality. What do you guys see? So in this one, I pointed out the peak P wave. What I was trying to show was a P pulmonale picture. In the study, they mentioned that they found predominantly P pulmonale and also right axis deviation. The EKG is from someone with COPD, but it pretty much shows similar findings. There's also a rightward deviation of the heart of the P axis and the QRS axes. There's also low voltage QRS complexes, especially in the left precordial leads. Something else that they mentioned on this specific EKG was also a clockwise rotation of the heart, which I was trying to find something that illustrates that. And it's basically just a more rightward deviation of the electrical activity in the heart. So in tuberculosis, there are several radiographic findings as well. On this EKG in particular, we can keep using that same, the same poll. I'll poll again. Feel free to shout out what you guys see on this image. Yep, great. So I see lymphadenopathy. In this one, we see that there's thickening of the right paratracheal stripe, consistent with lymphadenopathy, and also there's consolidation in the right middle and lower lobes. In TB, you'll have different findings based on whether it's primary versus post-primary disease. But clinically, what's more important, just keeping in the back of your mind, is to differentiate whether it's active versus latent disease. And parenchymal disease usually manifests as consolidations, usually in some sort of segmental or lobar distribution, but there's no actual predilection towards a particular lobe. in tuberculosis. You could have cavitation. Cavitation occurs, apparently it occurs only in a minority of patients with primary tuberculosis. And when it does occur, it's progressive primary disease. The presence of lymphadenopathy, though, is the big clue that points towards primary tuberculosis. And usually you'll get mediastinal and hilar lymphadenopathy as the most common manifestations. All right, our next image here. So there's some arrows pointing to the abnormality. In this image, what we're looking at is we're looking at an axial chest CT. We're seeing a what looks to be a loculated right-sided pleural effusion. There's thickened enhancing pleura, but apparently there's also infiltration exactly of the extrapleural fat. In tuberculosis, primary tuberculosis, you will see approximately pleural effusions in approximately 25% in cases in adults, with the vast majority of effusions being unilateral. Surprisingly, no pericardial effusion on this image. On this next image here. Great. So GON complex we'll go through in a little bit. What we see here is multifocal patchy opacities in the right upper lobe. There's thickening and upward shifts of the minor fissure. There's these patchy, poorly consolidated, poorly marginated consolidations is an early and consistent feature of post-primary tuberculosis. Consolidation and cavitations usually have a strong predilection for the apical and posterior segments of the upper lobes, as well as the superior segments of your lower lobes in post-primary tuberculosis. Although not seen here, you can also have bronchial wall involvement. This may be seen in primary and post-primary tuberculosis, although it's more common in the former. Bronchial stenosis occurs in 10 to 40% of patients with active tuberculosis, and it's due to direct extension from tuberculosis lymphadenitis by means of endobronchial or lymphatic dissemination. And we'll see a consequence of that later on. So anything you guys see here? Great, right below opacities, exactly. So here we see some bilateral calcified granulomas with fibrotic apical changes and lung volume reduction. There's more on the right side than the left. The granulomas, I think they're referring to are these little nodules more peripherally in the lungs. Inactive tuberculosis is characterized by stable fibronodular changes, including scarring and nodular opacities in the apical and upper lung zones. Fibronodular change, however, is associated with a higher risk of developing tuberculosis reactivation. So when you have involvement of the bronchioles, the bronchial walls, you'll have this finding here. Can anyone just shout out what they see? All right, so here we have a large cavitated lesion. It's in the right upper lobe. There's volume loss associated with it. We also see multiple pulmonary nodules, as well as this pattern right here. It's what's called a tree. It's what's called a tree and bud pattern. It's most likely post-primary tuberculosis. Active tuberculosis involves bronchial tree, and it results in endobronchial spread. Histologically, what's happening is that there's caseous necrosis and granulomatous inflammation. It's going and filling the respiratory bronchioles and the alveolar ducts. Radiologically, what you'll see is that there's central lobular nodules, as well as this tree and bud sign. So here is our image from tensionales. Gone focus complex, Ranke complex. Can anyone say what this one is? All right. So here we see what appears to be like a granuloma peripherally, but then this here, maybe some lymphadenopathy. Overall, it's a Gone complex. Granulomas are where you have the activated macrophages, T lymphocytes, the active bacteria, forms like this granuloma. That's referred to as the Gone focus, the granuloma. Once you have lymphadenopathy that's ipsilateral, then you'll have a Gone complex. You calcify all that, and then you'll have a Ranke complex. Clinically, I don't know how useful that is, but it's just something to, you'll have a better understanding on tests. And here is an image of miliary TB. This is when you have a hematogenous dissemination. You'll see these evenly distributed 1 to 3 millimeter nodules. Shifting gears a bit, we're going to go into some pharmacology at this point. Tuberculosis is treated with a combination of usually with a combination of 4 main drugs: active TB, Isoniazid, Rifamycin, Paraxinamide, Ethanbutyl, and sometimes you might add on some second-line medications depending on whether it's drug resistant. Latent infections you'll still treat, usually with Isoniazid, or you might combine Rifamycin, Paraxinamide for those that are resistant. Starting with Isoniazid. Isoniazid is the big drug that we see being used in TB treatment. It's a prodrug. It undergoes metabolic activation. It irreversibly inhibits some enzyme that helps with the synthesis of mycobacterial cell walls. It's rapidly absorbed. It has a peak serum concentration within 2 hours when you take it orally. The way that it works is that it's metabolized into several different compounds by N-acetylation, some of which are hepatotoxic. Just know that some populations just are fast acylators, meaning that they can metabolize Isoniazid faster than other populations, specifically Asian and Inuit populations. Isoniazid produces, toxicologically, Isoniazid can induce a functional paradoxine deficiency by inhibiting paradoxine phosphokinase. This converts paradoxine to its active form, paradoxal 5-phosphate. The active form is used as a cofactor for multiple reactions, including the conversion of glutamate into GABA and conversion of lactate to pyruvate. So ultimately, it messes with GABA synthesis. Toxicity is rapid, and it can happen within as soon as 30 minutes, 2 hours. Sometimes it could get delayed absorption, but it's infrequent, and delayed absorption usually will happen within the time course of somewhere around 6 hours. Acute toxicity can cause a clinical triad of seizures reacted to anticonvulsants, a severe metabolic acidosis, and coma. You can also get other symptoms like vomiting, slurred speech, dizziness, and tachycardia. These might manifest a little bit more earlier. You can also have patients that are more predisposed to having seizures from Isoniazid ingestion with those that have pre-existing seizure disorders. People who also that you find hypo or hyperreflexia in are indicators for those who are at risk for Isoniazid-induced seizures. Toxicity can occur in ingestions of 20 milligrams per kilogram, although it's more likely with higher doses. And chronic toxicity can also occur. Usually it's going to be hepatotoxic. Other adverse effects of chronic ingestion are peripheral neuropathy and optic neuritis. These are believed to be caused by paradoxine deficiency. The risk of optic neuritis typically is greater when you take Isoniazid together with another medication like Ethanbutyl or etanercept. The main course of treatment is going to be supportive care, monitoring, decontamination, and administration of paradoxine. Paradoxine should be equal to the amount of paradoxine that you give should be equal to the amount of Isoniazid ingested, with a maximum of 5 grams that are given. If you don't know how much was given, how much the patient took, you should still give 5 grams. And pediatric dosing, the maximum should be 70 milligrams per kilogram, up to 5 grams. I was going through Goldfrank's, and they mentioned early GI contamination if there's no contraindications with activated charcoal. However, I can only find very limited studies in humans, and I can only find one specifically stating that activated charcoal given after 1 hour didn't reduce the plasma concentration time curve. So it's unlikely to be useful given after 1 hour. You could also consider benzodiazepines, barbiturates. These potentiate GABA, work synergistically with paradoxine, but it's ineffective by itself. Phenytoin has no intrinsic GABAergic effects, should not be given. It also is a sodium channel blocker, so you might be having some additional side effects when you give it combined with isoniazid. Hemodialysis is rarely indicated for initial management unless there's kidney failure or unless adequate dosing of paradoxine is available. When you give these massive doses of paradoxine, paradoxine comes in very small vials, and so you just might not be in a paradoxine hospital for the treatment. For chronic toxicity, paradoxine is not going to reverse hepatic injury. However, it is used concurrently with isoniazid therapy to prevent neurologic toxicity. Another first-line medication is rifamycins. These are like rifabutins. They're a class of macrolide antibiotics. They inhibit RNA polymerase. Food can interfere with its absorption. That's the only thing really pharmacokinetically. It's widely distributed in the body. It might also impart a reddish color to all the body fluids, including the CSF, so just know that. In large overdose, you can have transient elevation of bilirubin. It also is teratogenic. In acute overdose, the most common side effects are usually gastrointestinal, however, like nausea, vomiting, diarrhea. Other common side effects include anaphylactoid reactions, fatigue, drowsiness, headache, ataxia, confusion, and obtundation. Chronic toxicity, however, might induce from chronic toxicity might occur from the nature of its like CYP induction. You can have hypersensitivity reactions, including fevers, chills, myalgias, even hemolytic anemias, thrombocytopenias, and interstitial nephritises have been reported. Be careful when giving it concomitantly with protease inhibitor because it could increase the rates of arthralgia, uveitis, leukopenia, skin discoloration. For management, it's going to be stop the drug. Activated charcoal is not routinely recommended for this. For ethanbutyl, which is another first-line agent, it's a bacteriostatic agent against mycobacterium, and it's first-line therapy, but typically not given as monotherapy. It inhibits something that's needed for mycobacterial cell wall synthesis. When taken orally, serum concentrations reach maximum within 4 hours. It's typically excreted into urine, and you might see that its clearance decreases with age. Overdose effects typically happen with ingestions greater than 10 grams. And the most common effect is unilateral or bilateral ocular toxicity, presenting as painless blurring of vision, secocentral scotomas, and less commonly with decreased perception of red-green discrimination specifically, and loss of peripheral vision. The toxic effect is usually dose and duration related. It's reversible when you stop the drug. GI decontamination is, again, usually not recommended, and hemodialysis is not recommended. Paraxinamide is a structural analog of nicotinamide, and it has a mechanism of action that's similar to isoniazid. It's a prodrug, again, which requires metabolization, and it's another drug that disrupts mycolic acid biosynthesis. In the body, it's rapidly absorbed. Its clearance increases with continued therapy, so you might need to increase its dosage with time. When it was first introduced sometime in the 1950s, it was taken at a dose of 40 to 50 milligrams per kilogram for a long period of time, and it was thought to be hepatotoxic. However, more recent dosing lowered the dosage to 30 milligrams per kilogram for 2 months, and now hepatic toxicity is infrequently observed. Some children have been reported to develop elevated uric acid concentrations. However, most patients remain asymptomatic, don't develop gout. There haven't been any actual overdoses reported from paraxinamide. Going into our second line medications, a lot of these medications have no reported overdoses either. The management of these medications is typically just stop the medication. For cycloserine, this is a medication which is, it affects some of the enzymes which are involved in peptidoglycan cell wall synthesis. It's a partial agonist at the NMDA and glycine receptor. With toxicity, you might see somnolence, headache, tremor, dysarthria, vertigo, confusion, irritability, and seizures. You could have psychiatric manifestations, including paranoid reactions, depressions, and suicidal ideations. Toxicity usually happens within the first 2 weeks, and it stops when you stop the drug. It is renally excreted, so it is reasonable to consider extracorporeal drug removal if you have CNS toxicity and impaired renal function. Ethanbutyl is another second-line medication. It's a prodrug that causes cell death by disrupting mycolic acid biosynthesis. It's rapidly absorbed, widely distributed. It crosses the blood-brain barrier, sorry about that. The most common effects are usually GI irritation and anorexia. You might also see orthostatic hypotension, depression, drowsiness. However, just know that it's also structurally similar to methimazole, and there have been reported cases of thyroid dysfunction. To stop the effects, stop the drug. Para-aminosalicylic acid, it's a drug that's incorporated into the folate pathway. It's a highly effective but also toxic medication, and adverse effects develop in as much as 10 to 30% of patients. They might involve GI symptoms like nausea, vomiting, diarrhea, sore throat, hypersensitivity reactions, usually in less percentage, like 5 to 10%. These might involve things like high fevers, rash, and arthralgia. You can also see hematologic abnormalities like leukopenia, agranulocytosis, eosinophilias, thrombocytopenia, and acute hemolytic anemias. Rifamycin, other second-line medications. With toxicity, you might see things like tinnitus, hearing loss, proteinuria, electrolyte disturbances. This medication interferes with ribosomes and inhibits protein translation. It's given intramuscularly, and there have been descriptions of pain and sterile abscesses at the site of injection. There haven't been any reported cases of overdose of rifamycin, however. Bedaquiline is a neuromedication. It's diacylquinolone. It inhibits mycobacterial ATP synthase. It can cause nausea, vomiting, headache, arthralgia, dizziness, QT prolongation. You should just be careful with patients that are taking other medications that work on CYP3A4, specifically some antiretrovirals like efavirenz. This medication, again, there weren't any overdoses described. Delaminid is probably the newest medication. It's used to treat tuberculosis. It's a prodrug that, again, inhibits synthesis of the mycobacterial cell wall. It can cause nausea, vomiting, tinnitus, headache, palpitations, and QT prolongation. But again, overdose is not described. We'll end with a final question. So in the VBox app, you'll see one final question just to end it all off while you guys answer that. Alrighty. So the correct answer, which treatment is not indicated? In this case, it would be fosphenytoin. Fosphenytoin has no GABAergic effects. It's also a sodium channel blocker, so you might have some additional toxicity in like toxicologically. You should manage as ABCs. You should give benzodiazepines because it works synergistically with paradoxine. You should give paradoxine. Paradoxine is the thing to give when you see isoniazid seizures. For our tuberculosis high yield, so to keep in mind, on the EKG, you can see several things. Sinus tachycardia is probably the most common thing we're going to see. However, you also look for things which are suggestive of pericarditis, pericardial effusions, or some sort of right heart strain. Suzanne mentioned the despotic sign is neither specific nor sensitive. Agreed. Radiographically, you might see primary or post-primary findings. However, the thing that's important to keep in mind is differentiate between latent and active infections. Primary findings, you might see some lymphadenopathy, consolidations, pleural effusions, or the miliary nodules. Post-primary infections, you might see consolidations in the apical and upper lung zones, nodules, and cavitations. The GON focus is the granuloma. Once you add in lymphadenopathy, that makes a GON complex. Once you calcify all that, that makes a Ranke complex. In terms of toxicity, keep in mind Isoniazid, Paradoxine. For the most part, stop the medication to stop the toxicity. Thank you.